Okay, all right, so we'll start with assessing EKG waves. All right, looking at a P wave, a normal P wave will originate from the SA node and spread through both of the atria. When you're looking at a P wave, it should be upright if you have lead 1 or lead 2 selected on your EKG monitor. When you switch over to lead 3, then it's going to look inverted, like upside down, or some of it might be above the baseline or below the baseline. All right, so here's some P waves.
I'm sorry, what was my phasing?
Some is above the baseline and some is below the baseline.
Like that picture?
Yeah, for the P wave, some of it's above, some of it's below, I guess by phasic. All right, if you see a tall peaked P wave, that tells you that you've got high pressures in your right atrium. Can you think of any examples as to why there should be high pressure in the right atrium? Back up, but why is there back up? Why would blood be backed up into the right side of the heart? All right, so left heart failure, everything backs up. Anything lung related that could lead to?
Pulmonary vascular resistance, high?
Yes, so high pulmonary vascular resistance, typically from COPD or lung diseases, pulmonary fibrosis. It'll cause pulmonary hypertension, and now the right heart has to work really hard, and you could end up with right heart failure eventually. So somebody with high right atrial pressures will have a tall, peaked P wave. If it's notched, like if it looks like the picture on the right, that means that one atrium is depolarizing before the other. So when there's necrotic tissue in the heart, the depolarization going through dead tissue takes longer and it slows down the conduction. So it'll make the EKG tracing look different. So if you have some necrotic tissue in the atria, instead of the P wave just being one P wave, it'll look notched because it's going through some necrotic tissue and it'll slow down the conduction. In really fast rhythms, you may not see the P wave, it'll be hidden even though it's still depolarizing. P waves can originate outside the SA node. So with a normal conduction system, we know that the impulses will start with the SA node and then spread through the heart. But it's also possible there could be an irritable area inside the heart muscle that can originate a P wave. If it originates outside the SA node, it's going to have a different look to it. And it could be upside down. All right, so this is giving you a general overview of all the different ways that a P wave could look like. You don't have to take it to heart yet, because when we go through specific arrhythmias, then we'll talk about, oh, okay, look, this is happening, this P wave looks like this because. So we'll address it specifically when we go through that particular wave, that particular arrhythmia. The QRS complexes are bigger than the P wave because of a larger muscle mass of the ventricles compared to the atria. When you're looking at a QRS, there's a Q wave, an R wave, and an S wave. So the Q wave is the first negative deflection from the baseline, and it says that it's sometimes absent. Most of the time, I don't see a Q wave. All right, so here's a picture, and there's no negative dip before you see this R wave. So we don't have any pictures of Q waves. When you guys had your electrodes on last week and you printed a strip of your EKGs, some of you had Qwaves, but not everybody. So it's a little bit of a dip right before our wave begins. So it says the first negative deflection, and it's tiny, and it's usually absent. So not a big deal, just to know where the letter Q belongs. The R wave is the first positive triangular deflection. So the big triangle is your R wave. The S wave is the first negative deflection that extends below baseline after the R wave. So it kind of goes right into the S. So the triangle is R. And then at baseline, that's where the R wave, you'd stop calling it the R wave at baseline. The rest of that you would call the S wave. And the Jpoint is where the S wave meets the ST segment, and it seems so arbitrary to me. All right, so Q, there was no negative deflection. It kind of just went into the R wave. Below baseline, we have our S wave. And then there's a point between the S wave and the T wave that's called the Jpoint. I don't ask you to find it on the EKG strips. I don't ask you about it on the exam. The Jpoint doesn't have a lot of emphasis when you're looking at EKGs. And to me, it's very arbitrary. Like, how do you know that's the Jpoint right there? So, yeah, I don't ask you to find the Jpoint. If the QRS complex originates at the AV node and spreads through the ventricles, the complex will be less than 3 small boxes or less than 0.12 seconds. But if the QRS originates from an ectopic focus in the ventricle, the complex is wide. So I need you to write down what it means for ectopic focus. So ectopic focus is an area in the heart other than normal conduction that initiates an impulse. So this is abnormal. An ectopic focus starting an impulse is something abnormal that happens in the heart. It's not supposed to happen. All right, so in the ventricle, if there's an irritable area in the ventricle, then it'll conduct an impulse through the ventricles. The ventricles will depolarize, and when you see that on an EKG rhythm, you'll see a big fat QRS. And when you see the big fat QRS, more than those 3 little boxes, you say, that's an abnormal QRS complex that must have originated somewhere else in the ventricle other than normal. So big wide QRS is abnormal. And this is kind of spread out. So here, I guess this is baseline right here. So the R wave is a little bit biphasic, and then the S. So from here to here, I think we've got more than 3 boxes. So it's really wide. Conduction through the ventricles may appear abnormal due to infarcted or necrotic tissue, fibrotic tissue, or an electrolyte imbalance. So this is saying that, okay, the QRS could go through the conduction pathway, but when the ventricle is depolarized, because you've got some old dead tissue in there, it's going to take longer to depolarize that dead tissue, and that's also going to cause the QRS to be wider than normal. So QRS could also be wider than normal if it's depolarizing dead tissue. If there's an electrolyte imbalance, is it possible that the QRS complex could be wider than normal? Yes. So electrolyte imbalance. Ooh, that would make a good test question, wouldn't it? Which of the following cause a wider than normal QRS? All right, then when you're looking at the PR interval, you measure from the beginning of the P wave to the beginning of the R wave. This is the time it takes for the atria to depolarize and send an impulse to the AV node and the His-Purkinje system. If there's a short PR interval, it occurs if the ectopic site is close to the AV node. Let me show you. Oh, bless you. All right, so beginning of the P wave to the beginning of the QRS. We're expecting that the atria depolarize, the conduction is sent to the AV node, and then through the bundle of His. And then after the bundle of His, then we see all the Purkinje fibers depolarizing the ventricles. All right, so beginning of the P to the beginning of the QRS, for conduction to travel through that area, it should take, do you guys remember from last week? 0.2 seconds or 5 little boxes? Yes. If it takes longer, it could be because there's necrotic tissue that the conduction is traveling through. All right, then it also told us, okay, this shows longer, and this is showing shorter. So if it only takes, this is saying 2 little boxes, from the beginning of the P wave to the beginning of the QRS, that's abnormal also. That means that instead of the SA node starting the impulse, it started somewhere else in the atrium, really close to the AV node. And that's why it didn't, whoops, where did I go? And that's why it didn't take long to get there. An upside down P wave is usually retrograde. Like the AV node actually initiated the impulse, and then the impulse spread through the atria backwards. And when it does, it looks upside down on the EKG. So all of these are going to be part of arrhythmias that we'll talk about at a future time. The ST segment is normally even with the baseline. Depression or elevation more than 1 millimeter from baseline is an indicator of myocardial ischemia or infarction. So depression or elevation more than 1 millimeter from baseline. I hope we have a picture here. All right, so this is showing the ST segment. It comes after the QRS and before the T. That's the ST segment. It's a real big deal when diagnosing if somebody's having an MI or a heart attack, because the change in that ST segment and where it lands on the strip of paper can tell you if there's infarcted tissue occurring. So elevation 1 millimeter would be 1 box above, or depression 1 box below. Say that again for the ST segment. If the ST segment is 1 millimeter higher than the baseline, or 1 millimeter lower than the baseline, indicates ischemic tissue and heart attack is occurring. All right, so the big catchphrase now is STEMI, S-T-E-M-I, and when you see it, it's always capitalized, capital S, capital T, capital E, capital M, capital I, STEMI. Can you figure out, after I've told you what I just told you, what that means?
ST, inversion, myocardial infarction.
Yes, very good.
Good job.
So ST segment elevation, S-T-E-M-I, myocardial infarct. So ST segment elevation, myocardial infarct. All right, so this shows a normal ST segment at baseline. This shows a depressed ST segment. So I don't know if they still say STEMI, if it's depressed by 1 millimeter. Bless you. Another depression. All the ones that I'm showing you are depressed, not elevated. But they indicate ischemic heart tissue or infarcted heart tissue. Did I tell you the difference between ischemic and infarcted?
Ischemic is like a plaque buildup in the artery, and then it just closes up.
No. So referring to muscle tissue in the heart, ischemia means there's lack of oxygen to the tissue, but the tissue has not died yet. So myocardial ischemia, there's lack of oxygen to the tissue, but the muscle has not died yet. So if perfusion reaches that area of the muscle and delivers oxygen to the muscle, then that ischemia is reversed and then the heart tissue becomes normal again. However, if a little bit longer period of time goes without the oxygen, then the muscle tissue dies. And then that would be infarcted or necrotic tissue. So dead muscle tissue is infarcted, I-N-F-A-R-C-T-E-D, infarcted tissue, or necrotic tissue. All right, and then the T wave is normally elevated when you're looking at it in lead 1 and 2. It can become inverted if there is myocardial ischemia. It tells you that inversion occurs due to the lack of oxygen, which results in leaking of potassium from ischemic tissue. So inside muscle cells, there's a lot more potassium than there is outside of muscle cells. But when there's death of the tissue, then the cell wall ruptures, and then there's leakage of potassium. And I guess once that leakage of potassium occurs, it's going to change the way that the EKG looks. So it'll invert the T wave. Okay, on the left, it's a little blurry. On the left, it shows a normal T wave, and on the right, it shows an inverted T wave. All right, the QT interval is the time for the ventricle to depolarize and then repolarize. It's prolonged when there's myocardial ischemia or infarction, and it'll be really short if there's digoxin toxicity. You learned about digoxin or digitalis when you took your pharmacology class? What does it do for cardiac contraction? Yes.
It's a
It
positive
increases.
inotrope.
Yay, good job. It's a positive inotrope, so increased contraction of the ventricle. So it's a dangerous drug because the amount that's used to therapeutically improve heart failure is so close to, if you take one extra pill, now you have digoxin toxicity in your blood. So it can be diagnosed by this short QT interval. The other thing that happens, if you have too much calcium in your body, it'll shorten the QT interval. So here it says between when the QRS begins to where the T ends, it should take 0.36 to 0.44 seconds. And we typically don't count this in this class, so you don't have to memorize that. All right, so now we'll get into arrhythmias. The word arrhythmia means abnormal rhythm. Sometimes you'll see the word arrhythmia, sometimes you'll see the word dysrhythmia, same thing. It's just abnormal, an abnormal heart rhythm. The first one tells you what normal is. So normal sinus rhythm. So if you're looking at an EKG and you'll see that everything is normal. It's regular, the rate is normal, P waves are normal, QRS, T, everything is normal. PR interval you measure, everything's normal. You're going to call that a normal sinus rhythm. You have to use all three words. You can't just say normal. You have to say normal sinus rhythm. Okay, so this comes right out of the textbook. It shows a picture of the heart. It's got the dotted lines going up to the conduction system and showing you. So P shows you the atria depolarizing. The QRS shows the ventricles depolarizing. It tells you the rate for this rhythm is between 60 and 100 beats per minute. So when we're doing textbook learning, of course the numbers are hard and fast. If you have a heart rate of 59, that's considered bradycardia. If you have a heart rate of 101, that's considered tachycardia, which really isn't true when you're caring for patients. But just to have definitions in place, 60 to 100 is normal. So the P waves look normal. There's one before each QRS. The QRS complexes are normal, and the PR intervals are normal. So if everything's normal, you call that normal sinus rhythm. Then if the heart is slow, you call that sinus bradycardia. So a rate between 40 and 60 per minute is sinus bradycardia. And typically this arrhythmia is normal for a lot of people, especially for athletes. Athletes will have a resting heart rate of 50, 55 beats per minute. So would you call that sinus bradycardia? You could, but then you would just say stable, meaning that they're not having chest pain, their blood pressure is fine, they're not sweaty, meaning that you've got poor perfusion to your periphery. So it would be a stable sinus bradycardia. It would be a normal rhythm for a lot of people, especially for athletes. So if it's unstable, it says describe what symptoms a patient has with an unstable heart rhythm. Do I have everything listed for you? No. Okay. So unstable heart rhythm would be, you want to just write the words unstable and then create a list? So unstable would be chest pain. Number 2, low blood pressure. Number 3, diaphoresis. Somebody has low perfusion to the periphery, they usually become diaphoretic. It's a symptom of being unstable. And then 4th, altered mental status. Altered mental status. So they're not responding appropriately. That's a sign that they're not getting good perfusion to the brain, and it's causing altered mental status. So that if I'm
next slide.
Yeah, there's another slide with all that.
Oh, I don't have it. Oh, man. Okay, so I guess I need to make a copy of the new PowerPoint.
Under symptomatic therapy? Yes, and they're symptomatic. The only one that's missing there is
Diaphoresis.
Oh, okay. Thanks, guys. So why would somebody have a heart rate that's slower than normal? Something could happen to the SA node. So there could be an occlusion of the vessel that feeds the SA node. Do you remember which vessel feeds the SA node? The circumflex in 50% of the population. And what about the other 50%?
The RAT.
Yes, the right coronary artery and the other 50%. Okay. So if that one of those vessels becomes occluded, now the SA node isn't getting perfused, it's not getting oxygen, and that can cause it to not initiate impulses. So myocardial infarct, dead muscle tissue could slow down the heart rate. Medications can slow down the heart rate. So patients that have hypertension, one of the ways of treating hypertension is to give them a medication that slows down the heart rate. So they'll typically have heart rates less than 60. Calcium channel blockers do the same thing. They'll slow down the heart rate. High potassium will cause a real slow heart rate. All right, so how do you treat somebody that has a really slow heart rate and they're symptomatic? There's medications that you could give. Atropine. So let's review atropine. It's very similar to Atrovent, isn't it? It's in the same category. Anticholinergic. Very good. So it blocks which system? Sympathetic or parasympathetic? Yeah, it blocks the parasympathetic system. And the parasympathetic system feeding the heart, does that slow it down or speed it up?
Slows it down.
Yeah, it slows it down. So when you give atropine and you stop the slowing down, what is left? Speeding up. So atropine will block the parasympathetic innervation and allow the heart rate to speed up. So atropine is an anticholinergic. It blocks the parasympathetic nerves and causes an increase in heart rate. With epinephrine, can you tell me the category that epinephrine falls in?
Ultra short acting.
The what?
Ultra short acting beta agonist.
Sympathetic. Isn't that?
Oh no.
It is short
Excuse me.
acting.
Just short acting.
That's true. So what category is this short acting medication in? It's an adrenergic drug, and adrenergic mimics the sympathetic nervous system. So are there any receptors on the heart that get stimulated with adrenergic drugs?
Yeah, the alpha and beta.
Okay, so beta 1 receptor sites are on heart muscle. And those beta 1 receptor sites, when they're triggered, it speeds up the heart rate. So beta 1, epinephrine is adrenergic, mimics sympathetic nervous system, stimulates beta 1 receptors, speeds up heart rate. All right, so epinephrine has alpha. I heard you guys mention the alpha receptor sites that will also be stimulated. It has the beta 1 that speeds up the heart, and then of course beta 2, which will cause the smooth muscle in the bronchi and bronchioles to relax. So it's got the alpha, the beta 1, the beta 2. All right, so if somebody has a really slow heart rate and you give them some epinephrine, it's going to increase the heart rate. So that's one of the treatments for symptomatic bradycardia. And then a pacemaker is, we have a lot of notes coming up about pacemakers, but it's an external source that can initiate impulses in the heart. So when there's necrotic tissue in the heart and the conduction system cannot conduct through the heart, then the patient needs a pacemaker to conduct impulses through the heart. Okay, sinus bradycardia. The rate is less than 60 per minute. Everything else is normal. P waves are normal. PR interval is normal. QRS is normal. T is there. Everything looks normal. The only thing you're going to notice is a slow heart rate. So would you call that bradycardia or would you call that sinus bradycardia?
Sinus bradycardia.
Sinus bradycardia. American Heart Association, oh, I didn't talk to you guys about ACLS, Advanced Cardiac Life Support. That's a course that you need to take before you graduate. And this course this summer that you're taking for the 6 weeks is perfect preparation for the ACLS course. You need to be ACLS certified in order to work in the ICU. If you decide to go work with pediatrics or neonates, then you're going to need that advanced life support also. But in order to graduate from the program, you have to be ACLS certified. The course is offered, you can find it in the community, and the prices get competitive. They want your business, so it's best to shop around. Maybe you guys can do it as a group and find a good place that'll teach you ACLS. So this course is preparing you perfectly. And we finish, what, June 23rd? So maybe between June 23rd and you come back in August, it's a good time for you guys to take the course and get that done so you don't have to worry about it during your second year. So it's an American Heart Association course, and they teach you the different algorithms. And an algorithm is just branching logic. So a person is complaining of chest pain, what do you do? And it's going to talk you through the algorithm. So in this one, I've got you showing what you do with a bradycardia. So let's go through it. You probably don't see it well in your notes because everything is really tiny. So you'll have to pull it up in D2L. Okay, so we have a heart rate less than 50 per minute. Put the patient on oxygen if they need it, hook them up to a monitor, make sure they're breathing okay. And then let's look to see if they have signs of being unstable. And if they do, the first drug is atropine. And then it tells you what the dose is. So as far as memorizing doses, you need that for the ACLS class. As far as memorizing doses for this course, no. So atropine is given, and that should speed up the heart rate. But what if it doesn't work? Then the patient might need a pacemaker, or they might need dopamine. Do you remember what dopamine is? I'll need you to write it down. So dopamine